Hey everyone, welcome to Pain Consultants USA podcast number 5. Today we're going to take a little break from talking about spine-related issues, and Dr. Bonner and I are going to be talking about tennis elbow today. It's very common. If you haven't experienced it at some point, I'm sure you know someone who has. This is something that affects men and women equally. Usually, you're probably somewhere between your 30s to 50s most commonly, and usually is due to an overuse type thing. So a lot of people who are active will experience this at some point or another. So we thought today would be a good opportunity to talk about that. How you doing today, Dr. Bonner?
Great, thank you. How are you?
Not too bad. So again, we're going to focus tonight on tendon issues. So I've always been a fan of tendon issues. I think they cause a lot of issues.
Get you to shut up about them.
I know. So we'll try.
Okay.
Keep me in line tonight. Why don't can you just kind of give a brief overview of what kind of everybody thinks of tennis elbow, or how it's kind of presents and things like that?
For us, what we see a lot is lateral elbow pain. So lateral being like the outside of the elbow. If I was to put my arm up here, it'd be right over here in this area, as opposed to the medial side, which is kind of over here. And again, as we always say, for anyone listening to the podcast, check out the video on YouTube because we point some things out there. So we see lateral elbow pain. Like you said, it's commonly an overuse injury, so classically called tennis elbow, but it could be related to some kind of other overuse injury involving a lot of movement of the wrist and the elbow. And we see pain in that area, tenderness, pain with movement of the wrist and sometimes the fingers. And then we don't tend to see any other like nerve-related issues like numbness, tingling, or weakness, unless you had like a major tear of the tendon, then you might have some weakness. But some of the other issues that we might think about with lateral elbow pain, we might see some numbness or tingling with those. We don't really see that with tennis elbow. So mostly pain localized to that area and related to some type of overuse injury. What else do you think?
No, yeah. I mean, when I see patients in the office, right? I mean, it's the nice thing about tendon issues, it's usually point tender, like you said, so they could usually point right to where it's bothering them. And usually on exam or just having the patient move their wrist and hands a certain way, they'll notice pain with wrist extension. Can you model that?
Wrist extension looks like this, moving your wrist up like that.
Yeah. So then if you resist that motion, or if you're even holding some weight in your hand and you try to do that motion, normally it'll cause pain on that outer part of that nice weight there. When patients present, right, you don't always just want to jump to conclusions at all. Any lateral elbow pain is tennis elbow. So, as physicians, we always run through our differential diagnosis. We always do a physical exam. So again, these are things that patients can also do at home if they're just trying to self-diagnose, right? So if you're having pain over the outer aspect of your elbow, worse when you're using the hand, holding things, gripping, trying to bring your wrist back, and you're wondering if it is tennis elbow, a couple of the other things you could look out for would be, like Dr. Bonner said, is there any numbness, tingling in the forearm, down into the fingers? Are you getting any like deep aching pain up in the upper arm area, or even in like the mid back, like between your shoulder blades? Some of the common things that will mimic tennis elbow sometimes are aggravated nerve or pinched nerve in the neck, right? people will describe like a deep toothache type pain. And if you have like C6 issues, which are very common, that could be over this lateral aspect of the elbow and into the forearm as well. So we always want to rule that out. Usually history and physical exam. Now you might have some numbness associated with that. There's something called posterior interosseous nerve entrapment syndrome. Just kind of a broad overview would be there's a small little nerve that gives strength into the hand muscles that kind of passes through this region. Usually it's about maybe 2 to 3 finger breadths below the epicondyle, or that kind of bony prominence on the elbow. So the pain is usually a little lower down, not right over the bone. And some people will actually have some weakness in the hand with that. Anything else you want to add to that?
I think that's pretty good. It's definitely one of the most common causes, so it's probably the first thing I think of when someone comes in with lateral elbow pain. But you definitely have to be aware of these other things, because if it's not tender right there, then it's probably not tennis elbow, and we probably need to think about something else. And like you said, the posterior interosseous nerve, you can palpate close to where the tennis elbow would be tender, like you said, 2 to 3 finger breadths away, and you can kind of mimic that pain, but it's a different spot. So you just have to be aware of where you're looking, and kind of what aggravates the pain and what makes it worse. And it could be very similar for those two things. So I think sometimes that's where, getting into, if you're not getting better, getting in to see someone might be a good idea to see if they can kind of sort out exactly what it is. And I guess we can talk about kind of how we sort that out with the different tests that we can do.
Yeah, I guess one thing for completeness sake, joint as well, the elbow joint. You have one of the two bones in your forearm is called the radius, and kind of where that begins, there's a radial head that sometimes within that joint can cause some issues. So, again, history is important. There might be some trauma with that. It might be maybe an older person with more arthritic type condition.
Do you find
and then the one
much elbow arthritis? I see a lot of geriatric patients, and I really don't see much elbow arthritis at all. Interestingly, very rarely.
It is very rare. Sometimes I'll see like more like the radial head itself if there was previous trauma.
Yeah. Post-traumatic is the time where I've seen it, like significant arthritis in the elbow. Yeah. But otherwise, I really don't think that I see very much of it. And I don't see a lot of people. I don't think I see a lot of people that have elbow pain really, but those that do, I'd say tennis elbow is one of the most common things I see. So.
Yeah. And then I guess the one other thing would be the biceps tendon, right? So the distal biceps tendon, I'm not sure if you could see me on the video, right? So the biceps comes down and it actually attaches in one of the bones in the forearm. And that can refer pain just generally in the area of the elbow. Again, exam can help with that too. Okay. So you have pain and you're wondering, well, what test do I need? Do I need an X-ray, MRI, or even an ultrasound? So what do you have a kind of a diagnostic algorithm that you normally follow, or what's your kind of imaging of choice for something like that?
I tend to bring an ultrasound with me everywhere I go. So I tend to take a look with the ultrasound first and see if I see anything obvious there. A lot of times in older patients, you're going to find tendon tears kind of all over the place, but I'll always take a look with an ultrasound first and see if I see anything obvious. I go with the physical exam too. If it's tender right there, kind of near the lateral epicondyle, I think it's typically pretty clear. I don't think I've ever really ordered an MRI for this. I have ordered an MRI to look for entrapment of the posterior interosseous nerve. An MRI could certainly be beneficial. It can definitely show differences in issues with the tendon. It can definitely show swelling of a nerve if a nerve is impinged. An X-ray in this case probably, unless we're suspecting a fracture or some type of arthritis like you were talking about, an X-ray probably wouldn't offer too much. Maybe some calcification if it's a chronic issue, but an X-ray probably doesn't offer too much in this case. So I tend to go with an ultrasound, and if I think it's more of a nerve issue, I might go more towards an EMG, which we've discussed in other podcasts, but kind of looking for some injury to a nerve. So those would probably be my two go-tos.
Yeah, I would agree with that. I mean, there are studies. I mean, an ultrasound of the tendon that's involved with tennis elbow, which is a bundle of tendons that, again, control this type of motion, right? So it's called your common extensor tendon. It's made up of a couple different ones, but it's superficial, so it lends itself very nicely to be evaluated with musculoskeletal ultrasound. Again, this is the type of ultrasound where it's not the type of ultrasound when you go to therapy and get applied to there, but this is ultrasound that, like what you get to look at babies. So you can see images underneath the skin. So, ultrasound for this area of the body is just as good when performed appropriately as an MRI to evaluate the tendon itself. So I would agree with you. Ultrasound, if ultrasound is completely normal, well, then I might want to consider another imaging modality.
Yeah.
But yeah, ultrasound, and that it's hard to kind of just talk about it without showing pictures, but that also gives us, clear cut. Okay, well, what's the cause? Is the tendon swollen? Is there a tear? Or is there active inflammation with these neo vessels or new blood vessels with little sensory nerves that have kind of grown into the tendon? And then that can kind of help with the treatment. Guide treatment as well.
I guess one other thing we should mention is just to differentiate for people kind of what exactly is a tendon and what is that versus a ligament. Typically a tendon is where is the tissue that connects a muscle to a bone, and a ligament connects bone to bone. So just in case you're wondering the differences between that's typically what that is. And like Dr. Connor said, this specific tendon is actually a bundle of multiple tendons, that the common extensor tendon that we're looking at. So there's a group of muscles that all kind of come into the same place in the elbow there, and their tendons come together to form this common tendon that is commonly injured in this case.
Yeah, and I think, we should also talk about, well, what happens to the tendon? Why is it painful? Classically, we've always referred to this as tendinitis, right? So anytime you hear itis, you think of active inflammation. Well, we've learned that that's not necessarily the case with a lot of these tendon issues. They're usually more chronic because it's a repetitive type injury, so it builds up over time. So, there's damage that's occurring and you don't experience any sensation or pain from that, but after it kind of breaks over to the tipping point, then okay, now you have pain. So usually in those cases, there's no what we classically think of as active inflammation, that would respond to anti-inflammatories, but the tendon itself becomes degraded, or there's little micro tears, if you want to think of it that way. And then all these little chemical mediators come in, new blood vessels come, and with the blood vessels bring these tiny little nerves. Nerves, when they grow into the tendons, are one of the thoughts behind why you have persistent pain as well. The difficult thing with tendon healing is they don't have good blood supply, right? Just like ligaments. So when they're injured, there's very little blood supply that goes to these areas, making recovery that much more difficult.
Yeah. So I think that's a great explanation of, why we might feel the pain. And I guess, the next thing is if we diagnose it, how do we make it go away? And sometimes it can take a while.
Yeah, I mean, usually these will all, or I should say 80 to 90% of them resolve within a year with conservative care. But again, we sound like a broken record, but patience and, smart activity modification is sometimes needed with these types of
Yeah, I saw
issues.
someone
So,
recently who was asking about it, and they were like, "Oh, someone told me to go get a shot. Someone told me to go do this." And he's like, "I don't really want to do anything." And I was like, "You could probably just not do anything, and it'll probably get better, but it's just going to take a while, It'll just wait a year, and it'll be better. So, most cases that's the case, and then we can do things along the way to help.
yeah, I mean, I always start patients, less is more
Right.
sometimes. So we always start with, exercise, as kind of our theme, but there's a specific type of exercise that has been shown to be better for tendons, and those are called eccentric exercises. Right now, we classically think of, when you flex a muscle, the muscle gets big. The actual muscle itself kind of shortens, right, and it creates like a bulge. So that's concentric.
And I'll show you here a
When you
picture of that. So this is a concentric extension of the wrist there. So I'm shortening the muscles that are on the top here to pull my wrist up like this, or my hand up at the wrist.
Exactly. And then the opposite of that is something called eccentric, and that's where you're lengthening the tendon in the
So that
muscle.
would be where I'm kind of lowering the weight with my hand slowly, and the muscle gets longer as we do that because it stretches around the wrist. So if I wanted to do just an eccentric contraction, I would lift my wrist back up with my other hand, and then I would slowly lower it down with this hand. So that's the eccentric contraction. This is the concentric contraction. Okay. And so those are the different types of exercises. And we typically talk about the eccentric one being the one to help with tendon healing.
Yeah, so I mean, these are things you could do at home, again, with very small weights. You build up. You do not have to go very heavy with this, even if you're a stronger individual. Um, if you're in therapy, they should be doing something like that as well. Some people, just for symptomatic relief, they'll freeze little, they'll do a little ice cube massage over the area, followed by like a little cross friction massage with literally the thumb kind of just going back and forth across the tendon, along with some of those eccentric exercises. If you're doing activities that do cause pain, I was talking to a patient yesterday. He's chopping his firewood, getting ready for the winter. He's got a bunch of lateral elbow pain. We know what it is, but he can't stop right now. He's got to get ready for the winter. So, you could always go to a local pharmacy or a medical supply store, and you could get one of those offloading braces, right? So you might see those little. Can you see my elbow here, Dr. Brown? You get one of those little elbow straps that kind of wraps around the whole elbow, and usually you'll put it kind of 2 finger breadths below that bone, and that's where the tendon is. And there'll be like a little firm area or balloon that within that strap that you would put right over the tendon. You would strap it really tight. And what that helps to do is just kind of offload some of the pressure experienced by that tendon when you're using the hand or the wrist.
I think a lot of patients
that's
actually
something,
end up getting those before they even come in. I know I played golf with someone a couple of weeks ago who was wearing them on both arms at the same time, which was pretty funny to watch, especially because the golf was like the aggravating factor. But he was just going for it with bilateral, tennis elbow offloading braces, and he finished the round. So
don't tell a golfer they need to
right,
slow down.
I'd never stop. So,
okay. So, we talked about how you would diagnose it, both clinically and then really ultrasound, again, is the imaging modality of choice. And ultrasound saves a lot of money too, right? So, there's different ways you could go about getting an ultrasound, right? A physician may refer you to a radiologist who does musculoskeletal ultrasound. Now, or some physicians themselves in the office can do this, like Dr. Bonner talked about. Do you want to just talk about which physicians, who might be the best type of physician to see, or who can do those types of
Yeah,
things?
I mean, probably a lot of people in our specialty, physical medicine and rehabilitation, are now trained in ultrasound to look for common issues like this. We certainly did a good amount of ultrasound, musculoskeletal ultrasound in our training. Um, Other people who might be picking it up might be some orthopedic surgeons. They might pick up some of that to do in their offices. You could certainly get a musculoskeletal ultrasound from a lot of radiology, centers. Um, that's something that can be done. Some of the issue there is that you get an ultrasound from someone who's not actually treating the problem, so maybe they don't know exactly what you're looking for, and they're not giving you the exact detail that you need. So it's often better if you know how to do it yourself, because then you can really focus in on where you think the problem is coming from and really try to hone in on a specific problem. Because like we talked about before with MRIs for the low back, when you get radiologic studies, sometimes there's so many things that are mentioned, but you might need a more focused exam on one small area. So, but certainly you can get it from a radiologist, and maybe some other pain doctors like anesthesiologists might be doing similar examinations in their office too. You worked with anesthesiologists. I'm not sure if they were doing much ultrasound at the place you did it, but.
Yeah, not really for kind of
Hmm.
musculoskeletal things, but I guess sports
Yeah.
medicine physicians, whether PM&R trained or family
Right.
medicine, a lot of them could probably help with that too. And you bring up a good point. Again, general rule of thumb with diagnostic ultrasound, if you can have the person who's clinically treating you, who examined you, do the procedure, you're much better off than having someone who, like a technologist or just a rad tech who is just doing the scan and it's going to be interpreted by someone else. And I think that kind of holds true for
Yeah.
most things. Anybody who's doing the exam, who can follow through and do whatever diagnostic testing or imaging that's required, usually you're going to have a better outcome, and the findings can be correlated with symptoms much more easily, often leads to less unnecessary tests, and even cost. Cost will be
Yeah, and
less.
I've certainly found some things on ultrasound that sometimes I'll send for an ultrasound at a radiology center just to kind of get a backup, and I send a lot of information with the patient. Hey, this is exactly what I think I found. Can you confirm, or do you think it's something else? Because it's certainly, I think it's a tool that I have. I think for me, I'm certainly not an expert in it, but I think it's definitely something that is useful to me. But if I don't know what I'm dealing with, I will pass it on to a radiologist to kind of see, because that's really what they do all day, is look at images and ultrasounds and X-rays and MRIs. So it's very useful. I think if you're with a physician who's using it to try and make diagnoses, it can be very helpful. And then if they don't know what they're seeing, the next best place is probably a radiologist who could really take a closer look with some very specific information
Okay.
about it. Yeah.
Okay. So why don't we kind of get into the next step of treatment where, you know, patient's done physical therapy or home exercise program that was appropriate. They've, done some activity modification, but they're still having the discomfort and functional limitations, right? So, do you have like a treatment algorithm with regards to like injectables that you might use?
I
Um,
typically will try one steroid injection if the patient is is willing to do so. Um, and just one to see if it helps. And some people it seems to help and lasts and great, the pain goes away and there's no problem. And other people it doesn't last and then we need to move on from there. So typically I would do one steroid injection with a little bit of needling of the tendon at the time, and then move on after that. I usually have patients follow up kind of 2 to 3 weeks after an injection to see what kind of effect it's having, and then kind of go from there. So start with that, and then move on to, if possible, like a PRP type injection, and see if that offers any benefit. What do you think?
Yeah, I would agree with that. So, just for some background information for our listeners and viewers, right? The concern about steroid with tendons, as we've kind of learned, is steroids, especially if they're injected into the tendon, can weaken the tendon, can oftentimes increase the rate of recurrence. So when you look at a lot of these studies, people who've had corticosteroid injected, they usually do good for the first, 6 weeks, but then there's a much higher rate of recurrence at 1 year than people who didn't have steroid injected. So it's always important. We always go over that with our patients. But I would agree. I mean, when you're in the real world, when you're looking at potential options, right, steroid is covered by insurance. And we'll talk about some of these other options that usually are more cash pay. It's usually a faster onset. And it's reasonable to consider doing one injection. And what I normally tell patients is if this injection doesn't completely resolve your symptoms and give you ideal pain relief for at least 6 to 12 months, then, it's not going to work. We're not doing another one. So usually the people who do well with the steroid injection, it's like a one and done type thing. Should be done under ultrasound because you should never inject steroid into the tendon itself. So the nice thing with ultrasound, again, you can visualize that needle and you put the steroid right over top of the tendon. Now you brought up some needling, which is important, right? So before you inject the steroid, what Dr. Bonner was talking about is you'll actually pass the needle through the tendon to try to bring some blood flow into that area, which also helps with the tendon healing. But you don't inject the steroid into the tendon. Now, years ago, when they would do a blind injection, you can't tell if that's going into the tendon or not. So standard of care anymore, I would say if you're getting an injection for tennis elbow, it should be done with image guidance. So, okay, I think you know how we feel about steroids for this area. The next kind of thing that we often talk about is this PRP, or platelet-rich plasma. This is where a physician or a provider will take the patient's blood, spin it down in a centrifuge. We'll get the plasma portion, which has platelets in it and all these little growth factors that help with kind of natural healing. And then we'll inject those into the tendon themselves. Now, this is not covered by insurance, so it's usually, I guess it's regional, but you're probably looking at somewhere between $300 to $500, depending where you're at. Would you agree with that kind of cost?
Per injection, too.
Again, should be. Yeah. So, I mean, that brings up an interesting point, right? Because PRP works almost the exact opposite of steroid, right? Steroid kicks in really fast. PRP takes, the studies say 8 to 12 weeks really to start kicking in. So you'll see, or I'll hear some patients say, they had 3 to 5 injections spaced out a couple weeks apart. In my opinion, in my practice, that's not correct, right? Because the PRP, you're not going to notice the benefits until 8 to 12 weeks. So if somebody wants to give you almost like a series of PRP injections, I would, I think that would raise a red flag for me that this might be a little bit of a money grab.
Yeah, typically I would do 1 or 2, and see what happens. So, I don't know. I'm not aware if there's been like studies on doing more, but you probably don't need the more. You need the time after you generate the healing response for the tendon to heal is probably what is most important.
Yeah. We're just going to get into the weeds for a second, right? So when the tendon is injured, right, there's kind of three phases to that. The first week or so, maybe 2 weeks, that's where there's the acute inflammation. Oftentimes we might kind of miss that phase, right? When we're really kind of experiencing the pain, it's usually in phase 2 or 3. And phase 2 is where we start to get new collagen to come in to kind of help to fix the broken down collagen, which collagen is kind of the what makes up the tendon, right? It gives it its strength. The new type of collagen that comes in is weak. It's what more elastic, almost like a rubber band rather than a firm, thick kind of rope. And during that healing process, while we're having pain, most patients will continue aggravating it. And what happens is that healing process never kind of goes through completion, right? So it's tendinitis, or we should more properly term it tendinosis, so that because there is no active inflammation, it's really a failed healing response of the tendon, right? It just doesn't heal correctly. So the whole concept behind PRP and whether we're needling the tendon is really to reinitiate a proper healing response. Right. So those types of injections should then be followed by appropriate rehabilitation program as well.
And what about what medications do you like to use for this? I don't think we got into that too much. I know you mentioned it a little bit, but do you like to use the nitro patches at all for this, or what do you like?
That's a good question. So yeah, when you think of medications, you have over-the-counters, right? You have the anti-inflammatories, which again, you probably shouldn't be using that frequently. It could actually impair the healing response. You have topicals, right? There's topical anti-inflammatory creams. Some people use, but yeah, then there is some interesting studies on the nitro patches, right? So the nitro patches, what people use who have angina, right, or heart issues. But you would take the smallest patch, cut it into a fourth, and start with that, and you actually apply it directly over the tendon. You have to be careful for like headaches and things like that that come along with the nitro patches. But there's some evidence that could be used for some of those superficial tendons. So once in a while, I will try that. Have you tried that with
I've ever prescribed
your patient population?
No, I don't think I've ever prescribed it. Again, I don't think
I've had mixed results.
Yeah, but I just haven't really. I don't think I've found a need for it. I haven't had too many like refractory cases for some reason or the other.
Yeah. I would say it's kind of mixed results, but it's always something that could be considered. Outside of that, I don't really use too many other oral medicines. Anything that you like a lot?
Not really. I mean, I tend to recommend Tylenol for mild pain, and for this, I don't think we need to get into other types of medications in terms of. I don't ever get into muscle relaxers or the neuropathic pain medications. And like you said, kind of limit the use of the non-steroidal anti-inflammatories. And I've never, had to prescribe anything stronger in terms of like an opioid pain medication for something like this in my practice.
Yeah, I would agree with that.
So I've never had to get to that point. And I don't think that would probably be an appropriate use of the medication. Unless somebody has really extenuating circumstances.
Yeah, I would agree with that. The injectables, the steroid and the PRP are probably the most common. When you look at the studies, there are really good studies for PRP for tennis elbow. So it's really hard for me to recommend anything other than that. As far as, like we said, the steroid, you know, you'll hear a lot about stem cell therapy right now. Stem cells, we'll do a whole talk on that at some point. I mean, it's much more expensive than PRP. And I just don't think it's really required based on the studies that are out there for the benefits with PRP.
Have you ever had to
there's
send someone to surgery for this?
So I have not in the last, oh gosh, I don't know, 4 to 5 years. Again, most cases, you treat conservatively, they'll get better. Those 10 to 20% that are refractory, they're the ones we're talking about doing these injections or possibly these ultrasound guided procedures. So usually with PRP along with needling. So again, you're making multiple passes with a needle through the tendon. So this is not a very pleasant procedure by any means, right? So patients will have pain afterwards. It's normal. And PRP itself is also very painful when injected. And you could talk about, well, do you use a lot of lidocaine or not? There's some studies, they're more in like test tubes, but when you mix PRP with a lidocaine type medicine or numbing agent, sometimes it can actually negatively affect how the PRP works. Now, does that happen clinically or in real life situations? I'm not entirely sure if there's any new studies to say one way or the other. So you could use a little bit of Novocaine. I'll use it in like the skin and underneath the skin, but I won't mix it in the same area I'm injecting the PRP. Right. That's it could be a painful procedure. But again, we're really trying to build or break down the tendon and kind of jumpstart the healing process. So it will be painful. And then there's always you can't use NSAIDs afterwards and things like that. So post PRP, it'll be a little painful, but it usually pays off as long as you do a structured.
Down, right?
Yeah, I mean, there's the talks of trying to avoid any kind of anti-inflammatory effect, right. But usually we'll couple that with activity modification followed by physical therapy with the goal to build up to eccentric exercises again.
So I always find it so interesting that we do this, but whenever anyone comes in with an injury, what do we tell them to do? Take anti-inflammatories, put ice on things. We tell them to stop inflammation, but then when they don't get better, we go back and try to create inflammation to kind of start the healing process again. So weirdly, I like personally never will take anti-inflammatories when I hurt anything, and I tend not to ice it down unless it really hurts. Because of that reason, I tend to think that unless it's really swollen or there's something really bad has happened, I tend to think that response is kind of a good thing. So I tend to just let the pain ride out the pain until it gets better. But I know most people probably don't do that.
Yeah, I mean, it's a very good point. I mean, I guess you could make the argument, well, if it's a brand new pain, and you take something and it goes away and, the next day, the following day, you're doing good. It's not something you have every day. Okay, maybe. But yeah, if it's a pain that you're having every day, maybe we should rethink how we kind of treat those conditions right up front.
Definitely.
Just for completeness sake, do you do anything with prolotherapy?
I don't. It's something that actually my dad talks about a lot. I think I mentioned in another podcast, my dad is also a physical medicine and rehabilitation physician, and my grandfather was as well. And my dad talks about it because he says that my grandfather was doing it 50 years ago. And so like everyone who's doing PRP always says, oh, they're just doing the same thing that they've been doing for, probably over 100 years now with prolotherapy. Which is the same concept. just in a slightly different way. You're kind of creating an inflammatory reaction, but through injection of a different substance.
Yeah, exactly. And oftentimes it can be cheaper.
Right.
There's some people that are, big prolotherapy individuals or believers. Again, I would, I don't personally do much with prolotherapy, but again, if you're having a procedure done under ultrasound, they're they're needling along with injecting whatever substance they're using for the prolo. Um, I'd just be cautious about like a series of these. Um, I guess that's like the cynical side of
Yeah,
me.
but I think in general, what you're saying is, if someone keeps doing something to you as a patient and you're not noticing any difference, then that should throw up a red flag there, unless there's a real reason to keep doing it and say maybe, oh, we'll see a benefit way down the road. If you're not seeing benefits within a few months, the treatment probably isn't working, and it's probably not worth continuing. And I see patients every day who have had the same kind of injection or procedure done over and over again with no real long-term or even more than a few week benefit, and keep getting it done, and you ask why, and they say, I don't really know. And so you should, as a patient, you should kind of take the initiative to say, well, why are we doing this again? If it didn't help last time, are you expecting it to be different? Are you doing something different? Sometimes you might do something that's very similar. Yeah, I might do an injection where I put the needle in under the skin in almost the exact same place, but the actual target under the skin might be different. And so if that's, that might be a reasonable explanation to do a different procedure, even though it's in this like almost the same exact area. So just as a patient, kind of take the initiative to ask, why are we doing this again? And what should I expect anything different? If it's a different procedure, maybe it'll work differently. If it's the same procedure that hasn't worked and you've had 6 months to evaluate whether or not it works, probably not a good idea to keep going through with it, you know?
Yeah, I mean, you highlighted a great point, right? I always tell my patients you have to be your best own
Right.
advocate, especially when navigating the current kind of landscape of our healthcare system. And I think the way you're able to do that is you ask appropriate uh, questions, right? So now, not all patients know what questions to ask, and I think that's our job. I'm hopefully um, they'll get out of this kind of our second order thought process, or what questions maybe to ask that would kind of throw up those red flags. So that's, I think, one of our goals with this podcast.
Yeah.
You know, one of the things or another question you could ask your providers, I know we're jumping around a little bit, but with PRP, right? Well, what kind of PRP are you injecting? Right now, the centrifuge that spins down the PRP, right? Each company will say, okay, this is the type of PRP it makes, right? And whether you do one spin or two spins, this is, how many red blood cells, how many white blood cells are in it. This is the concentration of the platelets, all those types of things. There's some studies. Studies do say, if you're treating a tendon issue with PRP, it should be one type versus PRP for maybe a joint issue should be another type.
Right.
So again, that's important to ask your provider, right? So if you ask them, well, what type are you using, right? So the main terms are leukocyte poor, leukocyte rich, right? So more white blood cells versus less. Within tendons, usually a leukocyte rich is fine. In the joint, usually you want a leukocyte poor. So if they can't answer that question, that's another kind of red flag. Again,
Yeah.
if you're going to do something, you have to do it right. So that's a good question to ask your providers if they're going to be talking about PRP.
And there's some PRP systems that claim to be PRP, but really just kind of remove the red blood cells and then just give you like a plasma that's not concentrated. And so that's not really platelet rich plasma. It's just kind of autologous conditioned plasma, I believe is what we call it. So it just has the red blood cells removed. And so we tend to think that a higher concentration of platelets is better. And so if you're not concentrating the platelets, you're probably less likely to have a good effect from that. So again, maybe asking about, well, what is the concentration of platelets used? Or just other things along that line. Is this autologous plasma? You might need a little bit more help trying to figure out things like that and what's more important. But those are good questions to ask.
Yeah. Before we kind of jump to the last kind of treatment with regards to either surgery or some more of this kind of needling type procedures, there's something that's called a tendon scraping procedure. That I don't do that often. It's when we see actual blood vessels, when we put the Doppler, which is just a setting on the ultrasound that will show blood flow. If we see the blood flow around the tendon, then you might be a candidate for a tendon scraping type procedure, where the goal is we actually use a little needle to disrupt the blood vessels, right? So it doesn't mean you bleed a lot. These are super tiny blood vessels, but we actually try to separate them from going into the tendon. Again, hard to talk about and not visualize, but that is an interesting procedure for people who maybe are more athletes, have a competition coming up. You don't want to use steroid because you run the risk of injuring the tendon. You don't want to do a needling or PRP procedure because you're out for at least a good 8 to 12 weeks, if not longer. So a tendon scraping procedure, right? Because that doesn't disrupt the tendon at all. We're not injecting anything in the tendon. We're not hitting the tendon with a needle. So we don't weaken the tendon at all. Is something that could be considered. So again, these are things to ask your provider once they've done the diagnostic ultrasound and you're trying to figure out what's the best treatment option for you. Have you done any tendon scrapings?
I have not done any tendon scrapings.
Yeah,
but
I've only done a handful.
Yeah.
So okay, then the last thing would be surgery, and I guess I group.
Is there one
Go ahead,
more?
sorry.
One other procedure that with the kind of the needle that is like an ultrasound, and then kind of like an ultrasound debridement. Okay.
Exactly. Yeah, I was going to kind of group that in with surgery, even though it's not true surgery.
Right.
I would try not to use brand names, but it's through, I believe, Sonics Health. It's called a 10X procedure, where there's a device that was created. It uses ultrasound, and it's literally like kind of, I guess, almost vibrates at a high frequency, but it can help, and then it sucks out the debrided tendon. And just studies are really good with that, right? I mean, I would there's a little more nuance to it, because I believe the last I checked, that has to be done at a surgery center for kind of reimbursement purposes, but it can be covered by insurance. But I think that's if I had a tendon issue that didn't resolve with everything we just talked about, and that was an option, I would go that option next prior to surgery.
Right.
So I've seen some good results with that personally. So
I've
and
heard
it's no more
I don't
painful.
do the procedure, but I've heard that it works very well. So I would definitely consider that as an option.
Yeah, I think you have to be trained with that. It's not like every provider who does PRP or things like that do that procedure. But I definitely think that's a good option. I mean, because when you talk about, well, what does surgery do, right? Surgery, they just debride the tendon, right? They go in, they remove, or they make the little incision. They could visualize the tendon without the use of ultrasound, and they just remove the bad tendon, right? They might drill little holes or like into the bone, or just find ways to get blood supply to the area as well. Now, the one downside with surgery is, right, the surgeons don't have x-ray vision. So you can have issues in a tendon on the top side, the bottom side, or in the middle. And with ultrasound, you'll be able to know that even better than MRI, as we discussed. So you can have a tendon that looks fine on the exterior. So when a surgeon's looking down at the tendon, it looks fine, right? But underneath that, there could be what we call the tendinotic tissue. So again, doing things with ultrasound guidance, I think, it lends to identifying those types of areas of pathology just better.
Yeah, I think, I don't know if we mentioned particularly, but with PRP, you tend to really want to put it right where the issue is. So you want to put that right inside the tendon. I think you mentioned that before, but so that kind of thing really needs to be done with ultrasound. The procedure for debriding the tendon, if you can see the whole tendon with the ultrasound, that doesn't, that's as good as anything else. You could certainly, like you said, just see the outside of the tendon. We might have to talk to a surgeon at some point to see kind of what their thoughts are about that and kind of how they go about the surgery. But it sounds like an ultrasound, even in that case, would be very beneficial for where they need to get to fix the tendon.
Oh, without a doubt. I think that pretty well covers the topic of tennis elbow. I mean, we're going to put out some educational information on our website. We'll probably even have it on our Facebook page that patients can check out. Again, as Dr. Bonner mentioned, you can listen to the podcast, or you can see the video on our YouTube page. But again, we're just trying to get as much information out there as possible. We want you guys thinking about, well, what questions should I be asking my doctor? And hopefully we give you a little bit of good information. You can kind of diagnose prior to getting to the doctor, start your treatment, and see how it responds even before getting to the provider.
Great. All right. Thanks a lot, everybody. Have a great night.
Okay.
See you.